This is an outcome of a pretty significant clinical quality initiative we've undertaken in setting up a new cancer centre. One of the issues that we face in setting up a cancer service, and Cancer Institute New South Wales has identified this, is the relationship between patient outcome with hospital or provider volume. That's been described in the literature fairly well for varying surgical sites and in oncology surgery. And there is a flow-on effect that Cancer Institute New South Wales is looking at for other services and looking at subspecialisation. This has also been seen in radiation oncology, though probably is unidentified in a lot of cases. This was a pretty good landmark paper that came out from the States where it looked at sophisticated radiotherapy implementation and looked at the amount of patients that a particular provider was treating. And you could see that with increasing numbers of patients that are being treated, you're seeing improvements in outcome, but you see worse survival in the clinicians who are not treating as many patients. So that volume effect in head and neck cancer is there. It wasn't seen for old-fashioned radiotherapy. They looked at the old-fashioned techniques, but for new sophisticated therapy techniques, there was a definite relationship between clinician volume and patient outcome. In New South Wales health radiation oncology, we do have significant clinical variation between practices in our radiotherapy departments. Cancer Institute New South Wales report on fractionation, or the number of treatments given for breast cancer, shows this diversity across the sites in New South Wales. So there is a potential issue in New South Wales. So in March 2013, the Central Coast Cancer Centre was established, a visionary, gave the funding under the Regional Cancer Centre grants, and the award of that grant to set up the Cancer Centre at Gosford Hospital was to the Northern Sydney Central Coast Area Health Service, but soon went over to the newly formed Central Coast Local Health District. Royal North Shore Radiation Oncology was seen as a potential mentor, but the way to implement this was uncertain. One of the key strategies, however, was that we wanted to maintain that regional cancer centre identity and the identity of the Central Coast. So we had a 2-LINAC department established, and there was a service level agreement between the 2 local health districts. So we had a couple of ways of implementing this model. One was the one where you maintain identity completely, and that's with patients who have got subspecialty or complicated, sophisticated treatments would just be seen at the regional centre and treated by a generalist, but they will get their treatment at the regional centre. Probably historically, this model was the mentorship model, where your high-volume metropolitan specialist would do an outreach clinic at the peripheral hospital or at the regional centre, see that subspecialty patient, and take them back to the main metro centre. But that was removing the identity of the Central Coast. So what was established, and it was really a vision from a couple of the main executives at Central Coast Local Health District, was to get that high-volume specialist from the metro centre, come and get them to work at the regional centre, and treat that subspecialty patient at that regional centre. And this is what unfolded. So we had a model of operation where 1 FTE was given away to 5 VMOs to bring those subspecialty skills to the Central Coast Cancer Centre. I was involved in neuro-oncology, and neuro-oncology was seen as one of these areas at risk with volume because Royal North Shore had a high-volume centre, but Central Coast had no neurosurgery service. And since 2007, there's been major changes with neuro-oncology practice, with much more sophistication, molecular testing, integration of radiotherapy and systemic therapies, and there's major variation in practice across Australia. So what we did was establish a service at the Central Coast Local Health District. I was appointed, and the model was that the specialist from the Metropolitan Centre was appointed as a VMO. A weekly clinic was performed. Patients were seen and treated at that centre. And that person then became the opinion leader for that service and collaborated with the generalist service on site. And so I collaborated jointly with a medical oncologist who then created that further subspecialty expertise. There was a seamless referrals from public and private. We had, importantly, digital links to link the 2 centres. And this allowed a very sophisticated service to be delivered. So we looked at key quality indicators to what happened over that time. And we had a group of patients who were treated at Central Coast before March 2013, ones treated after March 2013, and a cohort of patients who were treated at Northern Sydney Local Health District during that time. And we picked the glioblastoma multiforme because it's a very aggressive tumour where you can see potential clinical endpoints very quickly. And we could see that with clinical quality indicators being an indicator for how well the service performed. So we looked at sophisticated therapy delivery. Clinical trials were low on the Central Coast, much higher at Northern Sydney. We looked at sophisticated radiotherapy, and that was equivalent across all the centres and all the times. The use of Avastin, which is a sophisticated therapy, which is aiming to salvage patients need an established pathway, that was seen in equivalent, if not higher, at Central Coast. And reirradiation, which was another sophisticated therapy, was also delivered at a higher rate at the Central Coast. So we could see the Central Coast during this time was performing equivalently or better than the Northern Sydney, but with the exception of clinical trials. But the big endpoint was outcome of survival. And what we noticed when we benchmarked the survivals amongst the centres was that there was no statistical significance between all of them. And these results, even though they look poor in terms of short, median survivals, are very good for that cohort of patients. So we benchmarked them with international centres and international results, and we could see that we were performing at better or equivalent to the major randomised clinical trials which were performed and published during that time. So finally, the discussion points from this is this model of subspecialty manpower utilisation overcame that low patient volume effect that could have occurred at this regional cancer centre. But it requires motivated clinicians to develop that, smart use of digital technology links, and importantly, doing things like clinical audit to make sure you're on the right track. So I'd like to thank some of the people involved in this project, and specifically the Director of Cancer Service at Central Coast Local Health District, Campbell Tarley, and one of the executive officers, Andrew Roberts, who were very involved in establishing this initiative. Thank you.